All right, we are going to go ahead and get started. It's right at 9 o'clock. So tonight we are talking about tachycardic rhythms. So we are going to focus really just on three tachycardic rhythms: SVT, ventricular tachycardia with a pulse, and AFib with RVR. So if you remember from last time we met, we talked about bradycardic rhythms, and it was pretty straightforward because bradycardic rhythms are bradycardic rhythms. Well, in the very first meeting, I said I like to break down ACLS into slow, normal, fast, and dead rhythms, right? So as we get to the fast rhythms, there's really only three fast rhythms that we put in that bucket. There's only three rhythms that we categorize as being fast, even though there's way more tachycardic rhythms than that. There's only three that get to a rate that we really care about, that we start to try to intervene on. And we're going to talk about those three rhythms and what the appropriate treatments are for those. So as we jump in here, maybe. So the very first rhythm that we're going to talk about is SVT. So supraventricular tachycardia. So supraventricular tachycardia is a narrow complex. And what I mean by that is a narrow or a normal width QRS complex. So 0.12 seconds or less. It is regularly occurring, which means my R to Rs all march out and they're equal from one another. They're an equal distance from one another, and it is fast. So generally, we say that the beginning threshold for this heart rate is greater than 150 beats per minute. Okay. So narrow complex QRS, it is regular and it is fast, meaning greater than 150 beats in 1 minute. So we're going to talk about the treatments of this a little bit later on. So I'm not necessarily going to focus on the adenosine or the synchronized cardioversion at this time. But what I do want to talk about a little bit more is this supraventricular tachycardia, because I think it can trip you up pretty easily. So if you just break down that word, supraventricular, if we break this down, supra and ventricular, supra means above. Okay. So this means it is happening above the ventricles. So this is a rhythm, really a group of rhythms that is occurring from above the ventricles. And we know that because it's a narrow complex. Remember, our ventricular rhythms are all really wide QRS complexes, greater than 0.12 seconds or greater than three small boxes. And SVT, because it's a supra happening above the ventricles, supraventricular tachycardic rhythm, it is a narrow complex, a normal or narrow QRS width. And don't let those two words confuse you. Don't let narrow and normal confuse you, as they're synonymous to one another truly. Okay. So I have a picture of an umbrella here for a reason. So supraventricular tachycardia is truly just an umbrella term. It's not really a rhythm by itself. All right. So supraventricular tachycardia, or SVT, is really a collection of rhythms. So it could be sinus tach. It could be atrial flutter. Could be junctional tach. Or it could be um, atrial tach. So the point is with SVT, it is a regular rhythm. My R to Rs are all marched out appropriately. They are all evenly spaced. It is a fast rhythm, meaning it's happening more than 150 beats per minute, and it is a narrow complex. So when you get to those speeds at 150, 160, 170, 180, 190, and even into the 200s, which SVT can certainly go into, it becomes incredibly difficult, if not impossible, with some rates to really figure out, okay, is it a sinus tach? Is it an A flutter? Is it a junctional tach? Or is it an atrial tach? So the reason for that SVT term is It's going so fast. I don't know if there's an upright P wave and a T wave because it's just firing, firing, firing. I don't know if there's sawtooth P waves in there because it's going so fast. There's not enough time for me to be able to distinguish that. So with those rates, we're unable to pick out those defining characteristics of these four rhythms. So therefore, we just end up calling it an SVT, a supraventricular tachycardic rhythm, because we know it's happening above the ventricles and it's fast. So that's really why we call SVT SVT. It's not a rhythm by itself. It is one of those four. We just don't know which one it is. Now, sometimes you can push adenosine, which we'll talk about here at the very end of the presentation. You can push adenosine, and you might see that rhythm and rate go from 180 down to 120, 130, 110. And at that point, you might be able to pick out, oh, that's the underlying rhythm. That looks like sinus tach, or that looks like junctional tach, or whatever it may be. But that might not always be the case either. So at the end of the day, I don't really care which of these four rhythms it is. All I know is it's regular, it's narrow complex, and it's super fast, meaning it's more than 150 beats per minute, and I need to do something about it. Okay, so that's SVT. Oops. Come on. All right, there we go. So now let's talk about ventricular tachycardia. So we talked about supraventricular tachycardia. Now let's talk about ventricular tachycardia. So whereas supraventricular tachycardia is normal or narrow width QRS complex, ventricular tachycardia is a wide QRS complex. So we are wider than 0.12 seconds, or wider than 3 small boxes if we really measure this out. Okay. Remember, any ventricular rhythm, whether it's idioventricular or ventricular tachycardia or premature ventricular contractions with PVCs, regardless of what it is, if it is a ventricular rhythm or a ventricular beat, it is going to have a wide QRS complex that looks like a V, right? So remember that and correlate that into your head. Remember that VTAC can be pulseless, which then we put it into our cardiac arrest bucket, or it can have a pulse. And if it has a pulse, then we're going to apply that ACLS tachycardia rhythm to it. All right. So it's a wide QRS complex rhythm. Generally, it's really fast, again, like 150, 160 and higher. It can be slower. It can be like 120s and 130s. A lot you'll see that in textbooks, but at that point, there's also a good chance that it's another type of rhythm that we're not going to talk about tonight. And VTAC's kind of masking it, if you will. So for our sake and for paramedic school sake and for ACLS sake, if you see a ventricular tachycardia rhythm on the National Registry, I can assure you it is going to be at a fast rate. It's not designed to trick you. It's a regular, wide complex rhythm happening at 150, 160 and higher rates. Okay. And I didn't touch on that regularity piece earlier, so I'll touch on it now. VTAC is a regular rhythm. I don't mean it's a normal rhythm. I mean it's a regular rhythm, right? Meaning that my R to Rs all march out with one another and they are evenly spaced. Okay. Regular, fast, wide complex. It's got to be VTAC. Now, because it can be pulseless or it can have a pulse, if you get this rhythm on an exam, one, they should tell you what it is, that it either has a pulse or it doesn't. It might not be that blatant, right? They might give you some clues to lead into that. If the patient's sitting up talking to you, or they're complaining of chest pain, right? If they're complaining, they have a pulse. If they're talking, they have a pulse. But the other thing is, if you're doing like hands-on labs in the paramedic program, like static cardiology and dynamic cardiology, and your instructor changes the rhythm strip or they hand you a new rhythm and it's VTAC, the very first thing you need to do is there a pulse or no pulse, right? Because that dictates how we treat this rhythm. Am I putting it in my cardiac arrest bucket, which we'll talk about in 2 weeks? Or am I putting it in my tachycardia bucket, which we're going to talk about tonight? Okay. So this is a tricky rhythm because it can have a pulse and it can be pulseless. And again, we're going to talk about the interventions to all three of these rhythms at the end of this. So here's some different kind of morphologies of VTAC, so some different shapes and sizes of VTAC. The QRS complexes can be all negative, they can be all positive, they can be large, they can be small, okay? So VTAC can present in a few different ways just in terms of shape and size, but at the end of the day, the rules stay the same. It's fast, it's wide complex, and it's regular, okay? So don't let that trip you up. So now let's talk about AFib. And I'm not necessarily going to talk about controlled AFib. And what I mean by that is AFib with a normal or quote unquote slower ventricular rate of like less than 100. But since we're talking about tachycardic rhythms, I'm going to talk about AFib with RVR, or a rapid ventricular response. Okay. You can also hear that called uncontrolled AFib. So AFib by definition is grossly irregular, or you may have heard it called irregularly irregular, meaning there is no rhyme or reason to the QRS complexes at all. The rate varies. It can be controlled, which means less than 100, or uncontrolled, which means greater than 100. The P waves are not identifiable, right? Another way to say that is they are non-discernible. What that means is when you're looking at a 4-lead and you're looking at a strip, like the one that's on the screen here, you cannot confidently point to anything on there that says, yes, that's a P wave, right? They're all over the place. It's totally unidentifiable. There's fibrillatory waveform. Your P waves are fibrillatory. So what that means is when I look at this, it just looks like a bunch of squiggly waveform or maybe artifact, depending on the rhythm. Regardless, I can't look at it and say, yep, that's a P wave. Yep, that's a P wave. Yep, that's a P wave. It is all over the place. It's totally indiscernible. Okay. So if you get some type of description of an EKG rhythm and they say indiscernible P waves, AFib, I don't really even need to hear the rest of it. I can almost guarantee you the answer is going to be atrial fibrillation. The PR interval, of course, it is not measured. Why? Because we can't identify a P wave. I have to be able to identify a P wave so that I can measure my PR interval, right? And if I can't find my P wave, I can't give you a PR interval. The QRS width is always going to be less than 0.12 seconds, or less than 3 small boxes. Okay. So it's going to be an irregular rhythm, an irregularly irregular rhythm. My R to R's will not be equal with one another in the slightest. Okay. So it's irregularly irregular. There's no rhyme or reason to it. I can't even predict its irregularity. It can be fast or it can be slow. So it can be less than 100 beats per minute, or it can be greater than 100 beats per minute. We can't discern P waves, so we can't get a PR interval, and it is a narrow QRS complex rhythm. So it's less than 3 small boxes. Now with AFib with RVR, when you are going to hear that from a paramedic program perspective, we're most likely going to be talking about really fast rates. So again, higher than 150, higher than 160, maybe even into the 200s. So generally, I don't know your instructor, and I'm not going to pretend to, but generally an instructor isn't going to say the patient's in AFib with RVR and they have a heart rate of 108. They might. It's not necessarily wrong. It's just not terminology often used in the paramedic program. At that point, they'd probably say they're an uncontrolled AFib, right, at a rate of 120. Okay, so it's a little faster than 100. It's a little bit concerning, but I'm not going to do anything about it at the end of the day. Generally, when we start talking about with RVR and we hear those 3 letters, we're thinking 150, 160 and higher. So let's look at some practice strips before we talk about the interventions for these rhythms. So this one should look familiar because we just saw it. This is normal QRS complex width. Okay, so my QRSs are less than 0.12. So that is good. That is normal or narrow. Is it regular? As I march out my R to Rs, nope, it certainly is not regular. My spacing is all messed up there, so it is an irregular rhythm. Okay. Now, do I have any P waves? I don't have anything that I can say confidently, yep, that's a P wave. Yep, that's a P wave. Yep, that's a P wave. There's too much fibrillatory waveform there. Okay. So I don't have any P waves that I'm real confident about. And by that definition alone, I'm normal or narrow QRS complex width. I'm irregular. I don't have any discernible P waves. This is an atrial fibrillation. All right. So now let's assume this is a 6-second strip. I don't know if it is or not. I haven't actually counted the large boxes. But let's just say it's a 6-second strip. So I have 1, 2, 3, 4, 5. So I have 17 ventricular beats in this 6-second strip. How do we figure out that rate? 17 times 10 equals 170 beats per minute. So if this indeed was a 6-second strip and I have an Afib at 170 beats per minute, at that point, we're certainly talking about Afib with RDR. Okay. We are going to be guided to do something most likely on the National Registry exam for this patient and for this rhythm. And again, we'll talk about what it is. And I'm also going to talk about some personal caveats with this at the end as well. All right, so what do we have here? So first things first, is it regular? Okay, so if I mark out my R to Rs, yep, it's looking pretty regular to me. My spacing's all looking pretty regular. So yes, I would say this is a regular rhythm. Next thing I'm going to look at is my QRS width. So if I'm looking at my QRS width, I am definitely wide. I am definitely more than those 3 small boxes, right? So I'm going to say my QRS is greater than 0.12. When I have a wide QRS, I should automatically think it's ventricular, okay? Whether it's a PVC, whether it's an idioventricular rhythm, which just means it looks like this, but at a rate of anywhere from like 20 to 40 beats per minute, maybe 20 to 60, or it could be a VTAC. So it's regular, it's wide. Now, what is my rate? Again, let's just assume this is a 6-second strip. 1, 2, 3, 4. So we're right there at 150. And really, if you came down here to the very beginning of the strip, some instructors will tell you to count this as a half a beat. I'll leave that up to your instructor to clarify how they want you to do it on the exam. Neither one is wrong. But some instructors, if they see a QRS complex that is cut off like right in the middle, they'll say add 5 for that instead of adding 10. Hopefully that makes sense to you all. So this is 150 or higher. So it's wide complex, it's regular, it's greater than 150. It is ventricular tachycardia. If I just see this and only this, and I have no other information, the very first question I'm asking my instructor is, does it have a pulse, right? I need to know, does it have a pulse? Because if it doesn't, I'm doing cardiac arrest procedures. If it does, I'm doing tachycardia procedures. All right, so what do we have here? First things first, is it regular? I'm going to mark my R to Rs again, and you all are probably already tired of me saying that, but that's kind of by design also. You have to be systematic and you have to get set in your routine here. So yes, I would say my R to Rs are regular. They're all evenly spaced from one another. Okay. So I have a regular rhythm. Let's look at my QRS complex. Is it normal or narrow, right? Really all I care about is it less than 0.12? And yeah, it's maybe one and a half small boxes here when I measure that. So yes, my QRS is less than 0.12. And now what is my rate? It is also 17, so my rate would be 170 beats per minute. So now, on the second slide of this, or third slide of this, when we talked about SVT, I talked about SVT being an umbrella rhythm. There is truly no such rhythm as SVT. SVT is a term to classify a group of supraventricular tachycardic rhythms. Tachycardic rhythms that are narrow complex, and because they're narrow complex, we call them supraventricular, meaning they're coming from above the ventricles. Okay, so this is a perfect example of why that term SVT exists. So I put 4 rhythms into that SVT bucket, if you remember. I put sinus tach, I put atrial tach, I put junctional tach, and I put atrial flutter. Okay, so one of those 4 rhythms ultimately is what we're seeing here, but it's going so fast that we don't have an opportunity to really identify those independent, distinguishable factors about each of those rhythms. Okay. So I can't say, yeah, I think this is sinus tach, or I think it's junctional tach, or man, it might be an A flutter. I don't know. It doesn't matter. It's fast, meaning it's more than 150 beats a minute. It's narrow complex and it is regular. Therefore, we term it a supraventricular tachycardic rhythm or an SVT rhythm. All right. I think this is the last practice trip, and then we're going to start talking about ACLS treatments for these. Tonight's not going to be as long as last week when we talked about heart blocks, because we really spent a lot of time on going over heart blocks. So what do we have here? And hopefully, as I was taking a drink of water, you were already saying it. Is it regular or not? As I mark out my R's, they all appear to be pretty evenly spaced to me. Yes, I'd say this is a regular rhythm. Look at my QRS width. Is it narrow or wide? It is definitely wide, right? So I'm definitely at greater than 3 small boxes from beginning to end. So my QRS is greater than 0.12 seconds. So I have a wide QRS complex. And now let's look at our rate. (16, 17, 18). Like I said, some people might tell you to count that as a half a beat. For my sake, I'm just going to say it's 180 beats per minute. Okay. So 180 beats a minute. It's regular. It's wide complex. Does it have a pulse or not? It's either VTAC with a pulse or pulseless VTAC. Okay. Any questions from you all online thus far about the interpretation of SVT, the interpretation of VTAC, or the interpretation of Afib with RVR? I'll give you a second to respond or not respond, and then we'll move forward. All right. So we're going to keep moving along here. So now comes the treatment part. Okay. And this is where we're going to spend the most amount of time over top of everything tonight. So from a treatment perspective, last time when we met, we talked about the heart blocks, but we talked about symptomatic bradycardia. Now, the tachycardia algorithm and the bradycardia algorithms are not one and the same. That's an obvious, right? One's for slow rhythms and one's for fast rhythms. But what I mean by that is bradycardic rhythms, we're only treating those if the patient is symptomatic, right? They have to have something else going on in addition to their slow heart rate for us to really care and to do anything about it. So we're talking about chest pain, difficulty breathing, dizziness, lightheadedness, hypotension, altered mental status. Something else has to be going on in addition to that bradycardic heart rate for us to classify them as symptomatic and apply a treatment to them, either atropine or transcutaneous pacing. For tachycardic rhythms, and again, remember, we're talking about the big three, the SVT, VTach with a pulse, and AFib with RVR. We are going to treat those regardless. Whether you have symptoms or not, we are doing something for you. And the reason for that is your heart can't sustain and rates at 150, 160, 170, 210. Your heart can't sustain that. Okay. So we're trying to intervene while your heart is still able to have that compensatory mechanism so that we're not waiting until you're unstable, right? So if we have that stable patient, man, I feel fine. It just feels like my heart's racing a little bit. And you put me on the monitor and I'm an SVT at 190. Well, yeah, it should feel like your heart's racing, right? I'd be concerned if it didn't feel like your heart was racing. But we're going to do something about that before now I'm complaining of chest pain and difficulty breathing and my blood pressure's dropped and all these other things. So with tachycardia, we are going to classify these rhythms as either stable or unstable. Okay. Now, what I'm going to do for an illustrative reason here, I'm going to try to squeeze all of this in on one. So with SVT, I have a stable and an unstable. With VTach, and of course, we're talking about with a pulse, we have a stable and an unstable. And then I have Afib with RVR. I have a stable and I have an unstable. Let me move my little speaker box out of the way that you guys can't see. All right. So let's go to SVT. Actually, first, let's define stable, right? And we kind of already did. These are our patients that have incredibly vague complaints. Their blood pressure is fine. Their mental status is fine. They have vague complaints like I'm dizzy, I'm lightheaded, it feels like my heart's racing, my heart just feels funny. Those are stable patients, okay? The American Heart Association, which is who runs ACLS, right, and who really sets the criteria and all the algorithms for ACLS, they define unstable as chest pain, difficulty breathing, altered mental status, and hemodynamically unstable, which could be, excuse me, a low blood pressure, altered mental status. It could be signs of the patient not perfusing good enough. Okay, that's what hemodynamically unstable means. So let's talk about our stable SVT. And this is where I'm going to ask you guys, if you're comfortable doing so, putting in the chat box or in the Q&A, what you all feel is appropriate. What would we try first for those stable SVT patients? Vagal maneuvers. Good. So you are correct. Vagal maneuvers is first. And that always trips me up because I always forget about it. If we try vagal maneuvers, and how can we do that? We can have them try to blow through a 3 or 10 ml syringe to try to get them the vagal down. We can try to coach them through it and say, bear down like you're having a bowel movement, but please don't, right? So we can do vagal maneuvers to try to get them to stimulate that vagus nerve and convert on their own. If that doesn't happen, then we're going to move down to adenosine. We're going to give 6 milligrams. And how are we going to give that? Super fast, right? Rapid IV push immediately followed by a 5 to 10 milliliter bolus or a 10 to 20 milliliter bolus. So we're going to give 6 milligrams, rapid IV push, And then if that doesn't work, we can give 12 milligrams rapid IV push, immediately followed by that 10 to 20 milliliter normal saline bolus. The reason we are doing that is because adenosine has a 10-second half-life. So what that means is as soon as it comes in contact with blood, essentially, it has 10 seconds to get to the SA node to decrease conduction down to the AV node to the bundle of His. If that process takes longer than 10 seconds, if it takes the adenosine longer than 10 seconds to get to the SA node and the AV node to do its job, it's not going to do its job at all. Okay. So for my stable SVT, I try to vagal. If that doesn't work, I move to adenosine. I do 6 rapid IV push followed by a bolus. If that doesn't work, I do 12 rapid IV push followed by a bolus. ACLS says you can do another dose if you want to do 6, 12, and 12 to a total of 30. It's not in the algorithm anymore, but it is still contained in the ACLS provider manual. Again, if you've had cardiology thus far in your paramedic program, your instructor's probably already coached you to what he or she wants. But most programs, I think at this point, are just saying 6 and 12. And most protocols just say 6 and 12 as well. So that's stable SVT. Now let's talk about unstable SVT. So our SVT patients who are having chest pain, difficulty breathing, altered mental status, they're hypotensive. These are unstable SVT patients. So the very first thing we're going to do for them, you can try to vagal if you want, but that's not necessarily in the algorithm. What we are doing for these patients is synchronized cardioversion. Now, for these patients, SVT, the starting dose is 50 to 100 joules. And then 200, 300, 360. Now, the way I've always taught my students is start at 50, right? I would rather introduce the smallest amount of electricity possible to the patient to hopefully have the desired effect. But it doesn't matter. Overall, at the end of the day, it's a range, 50 to 100. You can start at 50 or you can start at 100. If those don't work, then we go to 200, 300, and 360. Okay. So those are all of our dosing for our SVT synchronized cardioversion patients. Now let's talk about our stable VTAC patients. So we are not going to try to vagal these patients. We are going straight to our medication. We are doing amiodarone, 150 milligrams over 10 minutes. So we are doing our amio, 150 milligrams over 10 minutes of time. And most people are going to put that in a 100 ml bag and infuse it that way. That's really the best way to give it. But you could also give it in a 10 cc syringe. Okay. And if you remind me at the end of this, I'll talk about that real quick. So that is stable VTAC. Amiodarone, 150 milligrams over 10 minutes. We're going to try to convert those patients out of that rhythm. Now let's talk about unstable VTAC. Just like we did in SVT, we are going straight to synchronized cardioversion. For these patients, 100, 200, 300, 360. Okay, that's going to be the flow of our dosage there. Start at 100. If that doesn't work, go to 200, 300, 360. And remember, this is synchronized. It's not a defibrillation. So anytime we are delivering a synchronized cardioversion, we hit the sync button on the monitor. We wait to make sure that the monitor is actually synced with the patient's rhythm, and we can recognize that because there's usually a triangle, a real small triangle above every QRS complex. Okay, whether it's wide or narrow, it doesn't matter. We're going to see that triangle above every QRS complex, and that's telling us that it's synced. When I select my energy level and I go to actually deliver the energy, you're going to charge the monitor, and then you're going to hold shock down for a few seconds until the monitor delivers the electricity. So it's not like a defibrillation where as soon as you push shock, the patient's receiving that electricity. With a synchronized cardioversion, you actually have to hold that button down for a few seconds for that monitor to sync and to look for the right time to deliver that electricity, or else it can end up being delivered at the wrong time. And then we have what's called an R on T phenomenon, and we put our patients into cardiac arrest, right? Bad day. So now let's jump over to stable AFib. AFib with RVR, of course, is what I'm talking about here. So high rates, 150 and higher. So stable AFib with RVR, the same theme that we've done with our other stables. We're going to do medication. So generally, this is cardizem, so some type of calcium channel blocker. The other word for that is diltiazem. And the dose, I'd be really surprised if you're asked the dose, but you might be, is 0.25 milligrams per kilo. Okay. So if it's a stable AFib, it is cardizem. Generally, certainly for the National Registry, what they want to know is, do you know the type of medication that needs to be administered? A calcium channel blocker, which would be cardizem or diltiazem. I've never seen the cardizem dose be on the registry. I'm not saying it's not possible, but what I am saying is I do think you're much more likely to get these dosing, the dosing from those medications than you are to get it for this. Excuse me. Everybody I work with is coughing right now, and apparently I am too. So now let's talk about unstable AFib with RVR. And I'm going to talk about the intervention, and then I'm also going to talk about why you should be weary of doing this in the back of an ambulance. So per ACLS, these people are also synchronized cardioverted. Their dosing is, of course, a little bit different. They are 120 to 200. 300 and 360. Now, any questions about SVT or VTAC before I erase this and talk a little bit more about AFib with RVR and the synchronized cardioversion aspect? So any questions about stable SVT or unstable SVT, stable VTAC or unstable VTAC? Remember, for all three of these, if it is stable, we are doing medication first, right? We have time to start a line, and we have time to drop a med, we have time to give med. If they are unstable, we are doing electricity first. We don't have time to start a line. We don't have time to draw up a medication. We're putting pads on, and we are synchronized cardioverting the patient. Okay. All right. I'm not hearing anything from anyone, so I'm going to talk about AFib with RVR a little bit more. Before we jump off and before I no longer have the ability to talk, apparently. So that's your heart, right? That's exactly what everybody's heart looks like. And so there's my four quadrants, right? Right atrium, left ventricle, right ventricle. So when we have a patient, a normal patient fires from their SA node down the internodal atrial pathways that I just drew there to their AV node, to their bundle of His, down their bundle branches, and into their Purkinje fibers, which innervate the ventricular muscle. Okay. So under a normal circumstance, my electricity is following this path, and it's causing my heart to contract from the top to the bottom. My atrias contract together, my ventricles contract together. My atrias contract together, my ventricles contract together. Now, the problem with AFib is that it doesn't follow that, right? Afib does its own thing. So remember with AFib, we have fibrillatory waveform. We have indiscernible P waves. The reason why is my atria are fibrillating, just like in ventricular fibrillation, where my ventricles are fibrillating, right? And I get that wide, chaotic waveform on the monitor, which we'll talk about in 2 weeks. With atrial fibrillation, my atria are largely doing the same thing. Okay. It's just not as detrimental to the patient because my ventricles are still working the way they should. So, with atrial fibrillation, what is actually happening is you have thousands of these sites in your atria, and they are called ectopic foci. And these ectopic foci sites become irritable in atrial fibrillation, and all of a sudden, all of them feel like they need to do the job of the SA node and the AV node. So they're all agitated, they're aggravated, they're firing off signals left and right. And because all of these ectopic foci are just firing off signals all over the place, my atria start to fibrillate. Every now and then, one of those signals actually makes its way down to the bundle of his and actually converts down into my ventricles, right? Which it's a good thing that it does because we couldn't live without it. So every once in a while, one of those impulses will actually get through that AV junction and get to the bundle of his and go down to the ventricles and cause a ventricular contraction. So per ACLS, and I want you guys to hear me when I say this, because I don't want to jam you up in paramedic school, but I think it's important to know this. And I would teach my paramedic students the same thing because I want them to, the first time they see this in the back of an ambulance, I want them to at least stop and think. So let me ask you guys, how well do you think your atrias are pumping blood and moving blood from the right atrium down to the right ventricle, right? And the left atrium down to the left ventricle? How well do you think the atrias are truly squeezing and filling and squeezing and filling in AFib? They're not, right? If they're fibrillating and they're doing this, well, that's not the squeezing and contracting that I want. So they're just fibrillating. So blood's not moving from my atria to my ventricles like it needs to, which can lead to other problems. But the big problem that I'm going to focus on right now is when blood isn't moving round and round the way that it should, what happens to blood when it sits? It coagulates. So as the blood coagulates, now all of a sudden, I'm starting to get some small pockets of blood sitting in my atrias, right? It's not really dumping or moving the way that it should. This patient's presenting to me in the back of the medic unit. Their heart rate's 175. They're complaining of some chest pain and some shortness of breath, right? They're not doing great, but they're okay. Just complaining of chest pain and shortness of breath, which by definition is unstable. But let's say they're perfusing okay. Let's say their pressure is 110/50. All right. So technically they'd be unstable. Technically, they would need to be synchronized cardioverted. So here lies the problem. How long has this patient been in AFib? I don't know. You're not going to know. They're not going to know. They may have been in AFib for 5 minutes. They may have been in AFib for 5 months. They may have been in AFib for 10 years. I don't know how long they've been in AFib. So my concern, Brandon Schoberg's concern is when I apply the ACLS treatment to this and I put pads on this patient and I synchronize cardiovert them at my 120 to 200 joules and I get them out of AFib and all of a sudden I get them back into a sinus tach or a normal sinus rhythm, what's going to happen now that my atria boom, start squeezing again, right? And they start contracting and filling and contracting and filling. Now, all of a sudden, all of the contents in that atria, whether we like it or not, are going to be dumped into the right ventricle, which goes into my lungs, and my left ventricle, which goes out to my body. So while I'm giving high fives in the back of the ambulance that I just got this patient out of AFib with RVR, with my defib pads. I got them in normal sinus since the first time since 2018. Now I just put a ton of clots into circulation, right? I just put a ton of clots into their lungs. I just put a ton of clots all throughout their body. So that's my personal big concern with synchronized cardioverting every AFib with RVR patient that I have, okay, which fortunately doesn't happen that often. But if you do have this type of patient, if nothing else, I want you to stop and think, man, should I really synchronize cardiovert this patient? Can we just get him to the hospital? Is it worth a call to medical control? That's what I would tell you to do. MD means makes decisions, right? Call them and get their perspective of, hey, I got a 72-year-old female. She is an AFib with RVR at a rate of 175. She's complaining of some chest pain and difficulty breathing. We don't carry cardizem, so I can't do it pharmacologically. Would you like me to synchronize cardiovert this patient? And I would bet you 9.9 times out of 10, the doc's going to say, just get them to me. Okay. Because they don't want to synchronize cardiovert this patient, at least not initially. Okay. They're going to try to bring it down with cardizem, with a calcium channel blocker. If they ultimately have to synchronize cardiovert this patient, it's going to be a slower process. It's going to be more controlled. They're going to have tried other medications. They're going to have given the patient heparin most likely to try to prevent some of these clots from causing a ton of damage. So it's just something to think about. Okay. If you get a test question in paramedic school, or you get a test question on the National Registry, and you have an AFib with RVR, and your patient looks like crap and they feel like crap, you better buzz them. Okay. 120 to 200 joules, 300, 360, and continue at 360 for an infinite amount of time. But what I do want to relay to you all is if you get this patient in the back of the medic unit and they're presenting the same exact way, if I'm back there with you, I'm personally going to say, hold on, let's call a doc first. Okay. Because I guarantee you the doc's probably going to say, hold off on cardioverting if you can, just get them to us, let us do our thing. And I'm totally on board with that. Okay. I'd rather high five people because we got them to the hospital and they're still alive instead of high fiving people because I got them at a normal sinus rhythm since first time since the 90s. And I dumped a bunch of clots into the lungs and into the central circulation. Right. So there's things to think about. And that's my biggest caveat with all of ACLS is a treatment has to be outlined, but I think it can potentially cause more problems if we're not careful and if we don't have a good patient history. So that's my soapbox about AFib with RVR. So any questions about AFib with RVR? That's my last slide. Like I said, tonight's a little bit shorter than it's that not that much shorter than the last time we met and covered bradycardic rhythms. Any questions about SVT, stable or unstable, VTAC, stable or unstable, or AFib RVR, stable or unstable? And again, like every other lecture we've done, the recording of this, I'll put the recording up within the next day or two in the community, and you'll be able to go back and watch it as many times as you want. So hopefully these have been helpful. Hopefully this was helpful. We don't meet next week on Thursday. We skip a week. But the last 2 weeks of February, those last 2 Thursdays, we are going to meet. We're going to do cardiac arrest rhythms next. So VFib, pulseless VTAC, asystole PEA. And we're also then the following week, we're going to do basic 12-lead EKG interpretation and STEMI recognition. I'm going to pause the recording.